Hello everyone. Today I will be talking about breast diseases with a special focus on breast cancer. So let's get started. So let's start with the breast structure. The breast has two main structures. The first one is the large ducts and the second one is the terminal duct lobular unit. So let's start with the large ducts. The large ducts are three-dimensional arborizing branching system, and this system starts here at this point in this figure with larger ducts, and then they're gonna branch into smaller ducts called segmental ducts, and then subsegmental ducts, and finally into the lobule. And here we reach the terminal duct lobular unit, which is the second structure in the breast. So this is considered the functional unit of the breast. Here the acini are grouped together in clusters to form lobules that are connected to the terminal ductules, and that's why it's called the terminal duct lobular unit. Furthermore, the breast has two types of epithelial cells lining the ducts and also the lobules in the terminal duct lobular units. The two types of epithelial cells includes the luminal cells and the myoepithelial cells, and here they are highlighted in two different colors. The luminal cells are highlighted in blue while the myoepithelial cells are highlighted in black. So look to the large ducts, the terminal duct lobular unit. Every structure is lined by the two layers. So the luminal cells are the innermost layer of the bilayer ductolobular system, and it's highlighted here as I said in blue, while the myoepithelial layer is the outer layer that rests on the basement membrane, and it's highlighted here in black. Furthermore, the breast has two types of stroma. One is called the interlobular stroma, and this stroma is highlighted here in red, and this stroma surrounds the large ducts and the terminal duct lobular unit, and it's composed of mature adipose tissue, which forms the majority of the breast volume, and also fibroconnective tissue including fibroblast, myofibroblast, blood vessels, lymphatics, and nerves. The second type of stroma is called interlobular stroma, and it's highlighted here in green. So it's the part of the stroma that surrounds the terminal duct lobular unit. So the breast has two types of epithelial cells and two types of stroma and two main structures. This figure shows the histology of the terminal duct lobular unit. And as you can appreciate here, it has architectural organization that looks like a tree, where the terminal duct here forms the trunk, and it opens into the smaller acini right here, which forms a branch of this tree. So they are the branches or the lobules. Before we start discussing the signs and symptoms of breast diseases, I want you to know that the underlying cause is benign in more than 90% of cases, and the likelihood of malignancy increases with age. So for example, the risk of nipple discharge being due to cancer increases from 7% in women younger than the age of 60 versus 30% in women older than the age of 60. So it's the same symptom, but the age of the patient is the main factor that increases the chances of this symptom or sign to be related to malignancy. Also, only 10% of the palpable masses in women younger than the age of 40 are due to cancer, while 60% of the palpable masses in women older than the age of 50 are related to cancer. So you may wonder and ask yourself if all patients with breast cancer are symptomatic, and the answer is no, because only 45% of the patients have symptoms, while the rest of them, which is about 55%, they come to the clinical attention through the screening tests. So only 45% of your patients are symptomatic. And the most common symptoms of breast cancer: palpable masses, followed by pain, followed by nipple discharge, and finally inflammatory changes. So it's about 50-50 percentage. 45% are symptomatic while 55% are detected by screening test, and here comes the importance of screening. So what is mammographic screening? Simply, it's a screening test that uses X-ray picture of the breast that is called the mammogram. And the mammogram, this X-ray, is able to detect early, non-palpable, asymptomatic breast cancer before metastasis. So you're gonna be able to diagnose the cases at an early stage. So you're gonna provide proper management and early management and better survival for your patient. And the average size of the invasive carcinoma detected by the mammography is about 1 centimeter, and at this stage most of the lesions are non-palpable and asymptomatic. And also at this stage it's considered early because only 15% may have metastasis to the regional lymph nodes. Also, the sensitivity and the specificity of this type of X-ray, which is called the mammogram, increases with the age of the patient. And this happens due to the normal replacement of the fibrous tissue of the breast, which is usually radiodense tissue that is present in a larger amount in younger women, with the fatty radiolucent tissue in older women. Regarding the clinical presentations of a breast disease, one of them is pain, or what's called mastalgia or mastodynia, and this is a common symptom often related to menses. This happens due to the cyclic edema and swelling related to the menstrual cycle. The pain can be also localized to a specific area in the breast, and this happens usually due to the presence of localized lesion, like ruptured cyst or trauma to the adipose tissue that is associated with fat necrosis. However, all painful masses of the breast are benign except for 10% that can be related to cancer for unknown cause. Inflammation is another clinical presentation of a breast disease, but this one is considered rare, and usually the inflammation is associated with edema and erythema. The most common cause of inflammation in breast diseases is due to infection, especially due to lactation and breastfeeding. The inflammation is an important mimic of inflammatory breast cancer, and we're gonna discuss that in the upcoming lecture. Now, nipple discharge can be normal, and usually this happens when it's small in quantity and bilateral. And it also can be a clinical presentation of a breast disease. For example, milky discharge, or what's called galacturia. This condition is associated with several etiologies. The top of them are related to elevated prolactin levels, like in pituitary adenoma, in hypothyroidism, in endocrine and ovulatory syndromes, and patients who are taking the oral contraceptive pills or some medications like the tricyclic antidepressants, the methyldopa, or the phenothiazines. Nipple discharge can be also bloody or serous, and this happens commonly due to the presence of large duct papilloma, and it may happen also during pregnancy, and this happens due to the rapid growth and remodeling of the breast tissue. فممكن يصير في عند البيشنت's bloody or serous discharge. However, if your patient have a spontaneous unilateral and bloody discharge, you should be worried, because this increases the concern for malignancy, and you should have a further workup for this patient. Another clinical presentation of breast diseases is the presence of palpable masses, which means the presence of masses that can be detected by physical examination. برغم من إنه about 95% of these masses are benign, all palpable masses require evaluation. So the evaluation of your patient is mandatory, and the workup is mandatory in those cases. The most common causes of palpable lesions are cysts, fibroadenoma, and invasive carcinoma. As I said, the palpable masses are the masses that can be detected through the physical examination, and they are generally detected when they are about 2 to 3 centimeters in size. Less than 2 centimeters, it's difficult to be detected through the physical examination. Gynecomastia is the only common breast symptom in male, and in this condition there is an increase in both the stroma and the epithelial cells due to the imbalance between the estrogens. So when the estrogens are elevated, and this will stimulate the breast tissue, and the androgens are decreased, and the androgens have like a counteracting mechanism against the estrogen. So الاسtrogens بيرتفعوا والandrogens بينزلوا، فهذا بيؤدي ل proliferation of the breast tissue. Let's start with the stromal neoplasms of the breast. The breast has two types of stroma, the intralobular stroma and the interlobular stroma. Tumors of the intralobular stroma includes fibroadenoma, which is the most common one, and phylloides tumor. Both of these tumors are biphasic tumors, which means that they are composed of stromal cells and epithelial cells. As the neoplastic proliferation of the specialized lobular fibroblasts that are seen within the intralobular stroma will also stimulate a reactive proliferation of the lobular epithelial cells. As the intralobular fibroblasts proliferate, they're gonna push and distort the epithelial cells. فالepithelial cells, they're gonna form like elongated slit-like structures rather than forming the round acini. The specialized stroma, اللي هي الانtralobular stroma, elaborate growth factors that will result in a proliferation of the non-neoplastic epithelial component of these tumors. So the neoplastic component of fibroadenoma and phylloides tumor is the stroma, while the non-neoplastic part is the epithelium. But the epithelium is stimulated through the growth factors released by the specialized stroma, and so it's gonna proliferate. But the neoplastic part of these tumors is the intralobular stroma, the specialized cell in the stroma. Let's start with the fibroadenoma, which is the most common benign neoplasm of the female breast. This tumor is related to the estrogen activity because it's composed of the specialized stroma that responds very well to the elevated estrogen levels. So this tumor may enlarge late in the menstrual cycle and during pregnancy, and when the levels of the estrogen goes down after menopause, they're gonna regress and calcify. The peak age of incidence is like the reproductive age ladies between the age of 20s and 40s. Usually the patients present with discrete, well-circumscribed, well-defined solitary masses that are freely movable within the breast tissue. And so the size ranges from 1 centimeter to 10 centimeters. And usually this lesion is easily shelled out surgically. فبالتالي a surgical excision is easy because it's well-defined discrete mass. This figure shows the gross appearance or the macroscopic appearance of the fibroadenoma. The white arrow here points to the fibroadenoma, and as you can appreciate, it's a very small mass here, but it's well circumscribed, well defined, and discrete and easily detectable if compared with the background breast tissue. Now you may wonder what is the blue color here. This is the blue dye that is used to mark the lesion during the fine needle localization in radiology, so that the surgeon could find the small masses within the breast tissue easily. This figure shows you the microscopic appearance of the fibroadenoma. As you can appreciate, it's a proliferation of the intralobular stroma. The intralobular stroma is increasing in size here and in cellularity, and this gonna push and surround the adjacent epithelium. So the epithelium will be compressed and form the slit-like spaces here. So you have overproliferation of the intralobular stroma that will result in distortion of the architecture of the ducts and the lobules. But look here, the border or the boundary between the fibroadenoma and the adjacent breast tissue is sharply defined because this lesion is well-defined lesion if compared with other tumors that we're going to discuss in a minute. Phylloides tumor, on the other hand, is another intralobular stromal tumor. However, it's much less common than fibroadenoma. And this tumor that comes from the intralobular stroma does not arise from a pre-existing fibroadenoma. Mostly your patient is an older age lady in her 6th decade of life, and the lesion shows leaf-like clefts and slits due to the presence of nodules of a proliferating stroma covered by the epithelium. The epithelial lesions of the breast are classified into benign lesions and malignant lesions. The benign category includes the non-proliferative changes, which includes cysts, fibrosis, and adenosis. also proliferative diseases without atypia, including the epithelial hyperplasia, papilloma, sclerosing adenosis, complex sclerosing lesion, and also the proliferative diseases with atypia, including the atypical ductal hyperplasia and the atypical lobular hyperplasia. While the malignant epithelial lesions include the non-invasive carcinoma, which is the DCIS, ductal carcinoma in situ, and LCIS, which is the lobular carcinoma in situ, and also the invasive carcinoma. The majority of the benign epithelial lesions of the breast are diagnosed incidentally during the mammographic screening. And the benign changes are divided into three main groups, as I said. The first one is the non-proliferative changes, including the cyst formation, the fibrosis, and the adenosis. And in this category, the lesions are not associated with an increased risk of breast cancer. بينما second category, which is called the proliferative disease without atypia, although this category is polyclonal hyperplasia, however, it's associated with 1.5 to 2-fold increased risk of breast cancer. Compare that with the third category, which is the proliferative disease with atypia, including the atypical ductal hyperplasia and the atypical lobular hyperplasia. Those lesions are monoclonal, which means that they are precancer, and they are associated with 4 to 5-fold increased risk of breast cancer in both breasts. The first group in the benign epithelial lesions is called non-proliferative breast changes, and this reflects that those lesions are non-proliferative, which means that they are lined by only single layer of luminal cells and a single layer of myoepithelial cells, so there is no epithelial proliferation. Those lesions are also called fibrocystic changes. So the morphologic patterns in these lesions include fibrosis and cyst formation. If you look down here, there are three principal morphologic patterns included in this category. The first one is the cyst formation, which is the most common. And those cysts, which means dilated spaces, are lined by a single layer of luminal cells that may undergo apocrine metaplasia, where the cells have abundant granular cytoplasm, apical snouts, enlarged nuclei, and prominent nucleoli. However, those cysts may rupture, and this will induce chronic inflammation and fibrosis in response to the spillage of the debris from the cyst content, and that's why they are called fibrocystic changes. Another morphologic change that included in this category is called adenosis, which means increased number of acini per lobule. The second group in the benign epithelial lesions is called proliferative disease without atypia. So here we have variable degrees of epithelial proliferation, including the luminal cells and the myoepithelial cells, but they do not show cellular atypia. Those lesions are commonly detected as mammographic densities or calcifications, or even incidentally when you investigate for another lesion. As we said before, those lesions are polyclonal, so they are not monoclonal, and they are not associated with genetic changes. So those lesions are considered as predictors of risk, but unlikely to be a true precursor for carcinoma, and the presence of these lesions increases the risk for breast cancer by 1.5 to 2-fold increased risk of malignancy. This group includes epithelial hyperplasia. So in epithelial hyperplasia, the lumen of the duct or the lobule is filled with mixed population of luminal and myoepithelial cells, but without atypia. The second lesion is sclerosing adenosis. From the names, adenosis means that the number of the gland is increased, and sclerosing means that the stroma shows fibrosis or sclerosis that gonna distort and compress the glands. So sclerosing adenosis, you have proliferation of the glands and fibrosis. The third lesion, complex sclerosing lesion. Now the complex sclerosing lesion, in this lesion you have central area of sclerosis, and this area is composed of fibrosis and elastosis, with the ducts and the lobules radiating outward. The fourth change is called papilloma, and in papilloma you see finger-like projections or papillae with fibrovascular cores that are lined by luminal and myoepithelial cells without atypia. The third group in the benign epithelial lesions is called proliferative disease with atypia. So now we have proliferation of the luminal and the myoepithelial cells, but the cells showed atypia. And those lesions, as we said, are considered monoclonal or precancerous, associated with like 4 to 5-fold increase in malignancy in both breasts. This category includes atypical lobular hyperplasia, where the lesions resembles lobular carcinoma in situ, and atypical ductal hyperplasia, where the lesions resembles ductal carcinoma in situ. So what's the difference? The difference that those lesions have some of the histologic features that we use to diagnose the carcinoma in situ, but not all of them. So the atypical lobular hyperplasia shows some of the features that we use to diagnose lobular carcinoma in situ, but not all of them. That's why we placed those lesions in this category. Same thing for the atypical ductal hyperplasia. So those lesions show some, but not all, of the histologic features that are required to diagnose ductal carcinoma in situ. Again, those lesions are monoclonal, precancerous, associated with moderate increased risk of carcinoma. Regarding the epidemiology of a breast carcinoma, breast carcinoma is considered the most common malignancy of women globally, and this includes the non-melanocytic skin cancer. And breast carcinoma causes the majority of cancer-related deaths in women. And the incidence and the mortality for this disease are increasing rapidly at an alarming rate, especially in the developing countries or the lower income countries. The major factors that underlie this trend in the developing countries are thought to be social change, including delayed childbearing, fewer pregnancies, reduced breastfeeding, and also the lack of access to the optimal health care. The lifetime risk of breast cancer is 1 in 8 for women living to the age of 90 in the United States, for example. And as I said, the incidence is increasing. So about more than 2 million women are newly diagnosed with breast cancer, 1/3 of whom will die of this disease. And almost all breast malignancies are adenocarcinoma. So the histologic type is adenocarcinoma. Regarding the risk factors for breast cancer, a large number of risk factors have been identified. However, we're going to discuss some of the most important risk factors. So let's start with the patient's age. Breast cancer is considered rare in women younger than the age of 25, but the risk will increase, or the incidence will increase rapidly after the age of 30. This means that the risk for breast cancer increases with age. So about 75% of women with breast cancer are older than the age of 50. And only 5% are younger than the age of 40. The second risk factor is gender. So being a female is a risk factor because the incidence in men is only about 1% of that in women. Family history of breast cancer is another risk factor. And the greatest risk is for individuals with multiple affected first-degree relatives with early onset breast cancer, and also the personal history of breast cancer if the patient himself or herself have previous history of breast cancer. Other risk factors include physical inactivity, so lack of physical activities and exercise, and increased alcohol consumption. Reproductive history, including early age of menarche. Menarche means the first menstruation, so the risk increases when the first menstruation happens younger than the age of 12. Nulliparity, which means that this lady never have completed a pregnancy. Absence of breastfeeding, and older age of first pregnancy. Also, ladies who are exposed to exogenous hormonal therapy, like postmenopausal hormone replacement, and also postmenopausal obesity. All these factors are associated with increased risk, probably because each increases the exposure to estrogen. Race and ethnicity are risk factors too. Studies showed that higher rates of breast cancer are seen in high-income countries if compared with lower-income countries. And according to the CDC, in the US, the rate of new breast cancer is similar across the socially defined races, but the age at the diagnosis is higher in European Americans if compared with the Hispanic Americans, for example. And this is due to social factors that are related to parity and breastfeeding. Another factor, Hispanic and African American women tend to develop breast cancer at younger age, and the breast cancer in this group tend to develop in an aggressive manner. And this happens due to the differences in genetics and also social factors and the access to the health care. Radiation is another risk factor. So radiation to the chest increases the risk of a breast cancer. And this is related to the time of exposure to the radiation, especially if the exposure happens while the breast is still developing. For example, breast cancer develops in about 25 to 30% of women who undergo irradiation for Hodgkin lymphoma in their teens and 20s. But the risk for women treated later in life is not elevated. So the risk for irradiation to develop breast cancer is related to the time of exposure. The major germline mutations that are associated with increased risk of breast cancer include BRCA1 and BRCA2 mutations and HER2 amplification. As you may know, BRCA1 and BRCA2 are classic tumor suppressor genes, which means that cancer arises only when both alleles are inactive or defective. BRCA1 and BRCA2 encodes for proteins that are required to repair certain kinds of DNA damage. And as you may know, they are normally expressed in many different cells and body tissues. Breast cancer risk increases in carriers of BRCA1 and BRCA2 in about 45 to 75% of these carriers by the age of 70 compared to 12% in general population. Regarding HER2 amplification, HER2 is a receptor tyrosine kinase that promotes the cell proliferation and suppress the apoptosis. Cancers with overexpression of HER2 are highly proliferative. Based on histology, breast cancer can be classified into non-invasive tumors and invasive or infiltrating cancer. A non-invasive breast cancer means that the neoplastic cells are still confined by a basement membrane, and they do not invade the underlying stroma, and there is no lymphovascular invasion. This includes two histologic types. The first one is ductal carcinoma in situ, and the second one is lobular carcinoma in situ. However, the second type of breast cancer is the infiltrating breast carcinoma or the invasive breast carcinoma. And within this group, we have different histologic patterns, including the invasive ductal carcinoma in OS, not otherwise specified, which accounts for about 70 to 80% of the cases, invasive lobular carcinoma accounting for 10 to 15% of cases, carcinoma with medullary features or medullary pattern accounting for about 5% of cases, mucinous carcinoma or colloid carcinoma accounting for 5% of cases, and tubular carcinoma accounting for 5% of cases. In the previous slide, we classified breast cancer according to certain histologic features into invasive and non-invasive breast cancer. So if the tumor cells are limited to the basement membrane and show no invasion into the stroma or lymphovascular invasion, then this is called breast cancer in situ, carcinoma in situ, including ductal carcinoma in situ and lobular carcinoma in situ. And if the tumor cells invade the basement membrane and infiltrate the underlying stroma, then this is called invasive or infiltrating breast cancer. And the invasive or infiltrating breast cancer is also classified into certain histologic subtype according to the histologic features. And this includes, as we mentioned, lobular carcinoma, tubular carcinoma, ductal carcinoma, carcinoma with medullary features, and the other histologic subtypes. Breast cancer is also classified based on the expression of three proteins, including ER, which is the estrogen receptor, PR, which is the progesterone receptor, and also the HER2, which is the human epidermal growth factor receptor 2, into mainly three biomarker defined subtypes or groups. And this classification is very important because this classification will affect the treatment for the patient according to the expression of these proteins. So according to the expression of these proteins, we have three major biologic groups. The first one is called luminal, and this accounts for 50 to 65% of the breast cancer cases. In this group, the tumor is ER positive, HER2 negative. HER2 group, which accounts for about 10 to 20% of cases, and in this group, HER2 is positive, ER can be positive or negative. And we have the third group, which is the triple negative group, which accounts for about 10% of cancer cases where ER, PR, and HER2 are negative. The three groups show striking differences in overall frequency, in patients' characteristics, in pathologic grade, and also in response to chemotherapy, metastatic sites, and the timing of relapse. That's why this classification is very important, because it's very important for treatment purposes and to predict the prognosis for your patient. This table shows you the three groups where we have striking differences in the patient characteristics, the pathologic features, the treatment response, metastatic pattern, the time to relapse, and the outcome. Non-invasive or in situ breast cancer. Non-invasive or in situ breast carcinoma includes ductal carcinoma in situ, DCIS, and lobular carcinoma in situ, LCIS. Both are composed of malignant clonal proliferation of cells. In both cases, the malignant cells are still limited by the basement membrane, so they are confined by the basement membrane and there is no stromal invasion or lymphovascular invasion. The extension of ductal carcinoma in situ through the lactiferous ducts into the skin of the nipple is called budget disease of the nipple, and the presence of budget disease of the nipple is often associated with an invasive carcinoma. Regarding the location, the most common location of a breast cancer is the upper outer quadrant, accounting for 50% of the breast cancer cases. So the most common location is the upper outer quadrant, followed by the central portion or the subareolar area, accounting for 20% of cases. The lower outer quadrant, the upper inner quadrant, and the lower inner quadrant, each accounting for 10% of cases. About 4% of women with breast cancer have bilateral primary tumors or sequential lesions in the same breast. Invasive ductal carcinoma is the most common histologic subtype of invasive breast cancer, accounting for 70 to 80% of cases, and it's also called carcinoma not otherwise specified. Usually, this lesion is preceded by precancerous lesion called ductal carcinoma in situ. Clinically, the tumor presents as mammographic densities during the regular screening or as a hard palpable irregular mass. Usually, this tumor shows positive expression of ER and PR and negative expression for HER2. Invasive ductal carcinoma is graded into three main groups according to certain histologic features. We have three histologic features that are used to classify invasive ductal carcinoma into the main three grades. The first one is the tubular formation. The second is the nuclear pleomorphism. And the third is the number of mitoses. This figure shows the three histologic grades. So if you look from the left side here, this represents a grade 1 well-differentiated carcinoma, because it shows frequent tubules, as you can see here, which is the first feature that we rely on, and also mild atipia, so the cells are a little bit monomorphic and there is no frequent mitotic figures in this tumor. So this is classified as a grade 1 well-differentiated breast cancer. Look at the figure in the middle here. This one is a grade 2 tumor, which means moderately differentiated breast cancer. There is less tubular formation than the first tumor, and there is more solidness of the tumor cells, and there is more atypia. Look at the third figure here, the one at the right side. As you can see here, this is a grade 3 tumor, which means poorly differentiated carcinoma, because the tumor cells are mostly infiltrating as sheets, and there is less tubular formation, if any. I cannot appreciate any tubular formation in this figure. And here is a higher power view showing the atypia and the frequent mitosis. Invasive lobular carcinoma is another histologic subtype of breast cancer, and this histologic type accounts for about 10 to 15% of all breast cancer cases. This tumor is preceded by a precancerous lesion in about 2/3 of the cases, which is the lobular carcinoma in situ. The tumors tend to be multicentric and bilateral in about 10 to 20% of cases, and presents clinically as a palpable mass or as a mammographic density. In terms of histology, invasive lobular carcinoma shows something called single file, where the tumor cells invade the stroma individually, so as single cells, and this is what we call single file, and this is characteristic for the invasive lobular carcinoma. This happens due to the loss of adhesion in the atypical lobular hyperplasia and lobular carcinoma in situ and the invasive lobular carcinoma, and this is due to a dysfunction in the E-cadherin. The E-cadherin, as you may know, is a transmembrane protein that contributes to the cohesion of normal epithelial cells in the breast and other glandular tissues. So the loss of the E-cadherin will result in loss of the junction between the cells, and so the cells looks like that they are infiltrating in individually, as we see in the invasive lobular cancer. Regarding the receptor profile, lobular carcinoma usually shows positive expression of ER and PR with negative expression of HER2, or maybe it can be seen in rare cases. This figure shows the histologic findings in invasive lobular carcinoma. As you can appreciate here, we don't see the tubular formation اللي لاحظناها في الانفيزيف ductal carcinoma، بل على العكس الخلايا هنا موجودين بشكل منفصل عن بعضهم البعض، so they are present individually, infiltrating individually as a single file, and this happens due to the loss of the E-cadherin protein، وبالتالي ما رح يصير في عنا tubular formation مثل اللي شفناه في الانفيزيف ductal carcinoma. Breast cancer can spread through the lymphatics and through the blood, and the majority of breast cancer gets metastasis to the regional lymph node. So first of all, the lymphatic drainage goes to 1 or 2 sentinel lymph nodes in the axilla. And if these lymph nodes are negative, then the remaining axillary lymph nodes are considered negative. That's why it's very important to take a biopsy from the sentinel lymph node. And this is a standard procedure to assess the regional lymph node involvement. So usually after the diagnosis of a patient with breast cancer, the surgeon will take a biopsy from the sentinel lymph nodes, which are the first 1 or 2 lymph nodes that receive the lymphatic drainage from the breast, and they send it to the histopathology lab. If it turns to be negative, then they consider that the axillary lymph nodes are negative, and if it turns to be positive, then they're gonna excise the rest of the lymph nodes. Regarding metastasis, the favored site for metastasis are the bone, lung, skeleton, and the liver, and also the adrenal. Less commonly the brain, the spleen, and the pituitary. In this slide and the next slide, we're going to be discussing the prognosis for a female with breast cancer. The clinical outcome for a woman with breast cancer can be predicted based on molecular and morphologic features of the cancer and the stage at the time of diagnosis. So in this slide, as you can see, 2 main factors are involved in determining the prognosis of your patient. The first one is the tumor stage. And the tumor stage, according to the TNM system, includes the T stands for the size of the primary tumor, and if the tumor is invasive or in situ at the time of diagnosis, the presence or absence of lymph node metastasis or involvement and the number of the involved lymph nodes, and the presence of distant metastasis plus the presence of local skin involvement and skeletal muscle involvement. The histologic grade, as we discussed, it depends on the tubular formation, the pleomorphism, and the mitosis. Another interesting point that tumors that are associated with high proliferative rates may respond very well to the cytotoxic chemotherapy. The histologic type of breast cancer can also affect the prognosis because certain histologic subtypes are associated with better prognosis, like mucinous and the tubular breast cancer, while certain histologic subtypes like inflammatory carcinoma are associated with poor prognosis. The expression of ER, PR, and HER2 are very important factors that may influence the prognosis and the treatment plan for your patient, because the expression of ER and PR by the tumor cells means that this patient is eligible for the anti-estrogen therapy, and this therapy will inhibit the growth of the cancer for many years. Furthermore, it's very important to evaluate the HER2 receptors for your patient, because evaluating the expression of HER2 receptors in the tumor will predict the response of the tumor into a monoclonal antibody used in the treatment of breast cancer and called Herceptin. Herceptin targets the HER2 receptors to fight the tumor cell growth, so this will decrease the growth of the tumor cells and also stimulate an immune response to destroy the tumor cells.